Another thing that I can never ever tire of saying is that when I was asked why this immunotherapy works so well by a guy in America when we presented it, he said, "Why does none of the other immunotherapies work in pancreatic cancer?" And I said, "Well, this is probably the first trial where we insisted that the vitamin D levels had to get into the normal range." He couldn't believe this. He said, "I've never heard of this, and I'm a very big pancreatic trial cancer person." His name was Daniel von Hoff, and he was he was huffing and puffing about this. But he phoned me 3 months later to say he'd put somebody on a study to check. He'd done 4,000 patients on different trials over 2 to 3 decades. And he came back and he said not a single patient responded to a single chemotherapy agent if they had a low vitamin D level. He was absolutely knocked out. And the really good ones that they put down to the later agents as they came along in the trials, that the responses were purely correlated with the fact these rare patients had high vitamin D levels. So with this, it's one of the things I've always said. We're going to stimulate the innate immune system. You must have a good vitamin D level first.
Which makes perfect sense because you've got vitamin D receptors in every type of white blood cell. You've got vitamin D genomic expression that depends on vitamin D dependent genomic expression in every type of white blood cell. It seems fairly obvious. Interestingly, though, that the patients with the high levels of vitamin D in the blood, did they actually do better? Was there like a dose response there?
Yes, there was. He confirmed that. He said he couldn't believe it. I mean, he spent 30 years doing this and hadn't realised it was that simple. Well, I must confess that we took a while before we realised that the difference between a responder and a non-responder was the vitamin D. We looked at virtually everything else and we only cottoned on to vitamin D when we were able to use the hospital's vitamin D testing service that they use for mothers and babies relative to rickets. And as soon as we could do it for adults, we found that it was the same. The only people who responded really well to the vaccines, including the immune modulators like IMM, were the people who had good, healthy vitamin D levels. It also highlighted that the NHS's idea of a normal vitamin D is really too low.
At least in this pathological situation.
In a pathological situation, because vitamin D is too low in the general population, because this is a population that is very white-skinned and exists indoors most of the time, so it doesn't get a chance. And then people who've got darker skins, it is far, far worse. So that they definitely need supplementation.
It's interesting. So for years you'd known that some patients respond to your chemotherapeutic regimes and some don't. And the reason that the non-responders didn't respond is because they were low on vitamin D. It was that simple.
Yeah, it is that simple.
That's so obvious once you know. But so what sort of levels do you like to titrate up to for chemotherapy?
I like to get it over 100 nanomoles per litre.
Yeah.
The NHS normal is 50 nanomoles per litre. So it's far too low.
Yeah, so over 100. But that's still only about sort of 35, 40 nanograms per mil, isn't it? It's not.
Yeah, and the upper limit of normal is usually 200 to 220, so it's nowhere near toxic.
No.
Absolutely nowhere near.
And even then, in your career, have you seen a case of vitamin D-induced hypercalcemia?
It's very difficult to say. My direct question is no. But I have heard of it occurring in children where the mothers are given ludicrous high doses because the kidneys can't take it. You've got to be very careful giving vitamin D supplementation in renal failure.
Right.
And certain people with rare phosphate genetic pathway abnormalities. Apart from that, you normally just pee it out. If any excess, you have a thermostat. And once the vitamin D goes up, I mean, there's some people you can give grams to nearly, and they'll never go above 120.
Interesting. So even though it's a fat-soluble vitamin, because traditionally I would teach that it's water-soluble vitamins that are urine excreted. But here we have a fat-soluble vitamin that's actually urine excreted. You can test the urine and find high levels of vitamin D in the urine if you give large amounts. It's just it just seems complete no-brainer not to do that. Is this done now in cancer centres around the country? Is vitamin D replete?
Slowly. But I just cannot believe the number of people I get referred for second opinion. Will you please see this person? They've been on all the right treatment. They're not responding. Have you got any sort of magic, this, that and the other? And I find they've never had their vitamin D measured from, big cancer centres, which I won't name. And I measure the vitamin D and it's really low. And so that's the first thing I do, boost it up. And I thought, that should not be my job.
No,
it should.
You should get to a professor to do that. The junior should do that.
Well, exactly. Anyone comes near me should have a very good vitamin D level. It's not my job to point out you've just had a year of treatment that's a total waste of time because you've got a low vitamin D level. It's unbelievable.
And the human suffering and the financial cost involved in that. It's just unbelievable.
But even hospitals with very good reputations are not getting vitamin D measured in a lot of their patients.
Yeah, incredible.
In fact, the people who do push for it are actually the dietitians.
Yes.
Not the doctors, not the oncologists.
Yeah.
The oncologists will say, well, there's no good evidence. Of course there's good evidence. They just never ever bother to do the research on it.
So two